Dr. Rebecca Lopez. She's an associate professor in the Department of Orthopedics and Sports Medicine and the director of the online post-professional graduate athletic training program at the University of South Florida. She is on the Medicine and Science Advisory Board for the Corey Stringer Institute and is currently serving as secretary for the Athletic Trainers Association of Florida. Her research interests include exertional heat stroke and other exertional heat illnesses, cooling methods for hypothermic athletes, youth sports injury, sickle cell trait in athletes, hydration and exercise performance, and preventing sudden death in sports. She has published over 40 peer-reviewed publications and has numerous national presentations, mostly related to exertional heat illness, hydration, and preventing sudden death in sports. Please welcome Dr. Lopez.
Thank you. Am I on now? Am I on? Oh, good. Thank you for that introduction. Thank you, John. And I want to start out by thanking the Valley Athletic Trainers Association and the SPATS committee for inviting me to speak here today. It's so far so good when you show up at a conference and there's a beautiful beach right next door. It's not too bad. So I'm going to talk about this really important topic on returning to play following exertional heat stroke. One of the reasons I'm really passionate about this is because every year a lot of athletes are dying from heat stroke. Actually, just a few days ago, the latest news is that one of the new college recruits that passed away after practice, it seems to be hyperthermic related or heat stroke related. So we still have a lot to do. A lot of the research in the last few decades has really focused on recognition and treatment, and we've come a long way when it comes to that. But then now we're having athletes that are having heat stroke, we're recognizing and we're treating it, and then they come back to us and we're not really sure what are we supposed to do as far as return to play, because this whole time we've been really focusing on the preventing death from heat stroke aspect. So what we're going to talk about today, hopefully by the end of this talk, we'll have a better understanding of possible complications associated with heat stroke, the different physiological tests that an athletic trainer could use when making considerations, maybe together with a physician on returning to play following exertional heat stroke, and also the importance of a team approach, like everything else with athletic training, working with the physicians, working with the athlete, working with the parents if it's a minor, and strength and conditioning coaches, team coaches, etc. So I just want to go a little bit of a background as far as thermal physiology. You guys are probably pretty well versed in this information, mostly just because it's really hot outside, so you kind of live it every day. But when you're in the hot environment, as you can see, the little guy to the left for a cool environment has most of the blood shunted to the core to keep you cooler. I don't know if you can see that. And then the guy on the right, in a hot environment, most of that blood flow going to your organs is now going to go to your skin, to your periphery, to your working muscles, and try to cool you the best way possible. So you have that peripheral vasodilation, increased blood flow to the skin, you increase sweating response, and hopefully dissipating that heat to the environment. I don't know if you guys remember this from probably modalities, but the whole convection, conduction, all that heat transfer, this is really relevant to athletes participating in a hot environment because you have a lot of things going on. You have the increased blood flow to the muscles, that metabolic heat production that is now storing heat, and then your body is trying to get rid of the heat. So today's talk is on return to play, but it's really important that we kind of work backwards. So what causes a heat stroke? Why did it happen? And then work from there for the return to play process. Another interesting thing, and my understanding is that how many of you work in the secondary school setting or with young athletes? So most of you. It's important to be aware of potential differences with thermal physiology with the younger population. They're not that big of a difference, especially as you get older high school athletes that have gone through their maturation. But before maturation, children do absorb heat at a higher rate. They don't rely as much on evaporation of sweat from the skin. They rely more on dry pathways. They usually tend to have, most of the studies on children and hydration and sweat rates, they have lower sweat rates just because their thermal physiology is just not as developed, just like everything else in their body that is not quite developed. So as they mature, they do kind of catch up to adults as far as, I turned it off, as well as far as their ability to dissipate heat. So let's focus on heat stroke. Some of the basics. It is the most severe exertional heat illness. I'm sure that you guys are aware that NATA updated their position statement on exertional heat illness 2015. If you haven't taken a look at that, I would highly recommend that you take a look at that because it has the most up-to-date recommendations as far as heat illnesses in general. But heat stroke is defined as hyperthermia greater than 105 degrees Fahrenheit or 40.5 Celsius. Usually have CNS disturbances along with that, and depending on the severity and how high their temperature is, often you will have multi-organ system failure, which is what the actual cause of why athletes die from exertional heat stroke. So what happens is you have all this metabolic heat production, environmental heat load, and if your body is not able to dissipate the heat as well, you end up with having more heat production than you have heat loss, and that causes that rise in temperature. Now, if we look at the epidemiology of exertional heat stroke death, it's pretty sad because at this point, a death from exertional heat stroke is 100% preventable if you have proper recognition and proper treatment. So if you take a look at these numbers, they're pretty staggering. In 2005 to 2009 had the highest heat stroke deaths in a 5-year period. If you look at that last bullet, 58 American football deaths from 1980 to 2009, mostly in the high school setting. Okay, so what are some of the reasons why athletes die from exertional heat stroke? Misdiagnosis, not having an accurate temperature or not being sure what it is at the time, a care or delay in treatment, inefficient cooling, immediate transport to the ER, and returning to play too soon. If you take a look at some of the stories and the information from Corey Stringer when he died from heat stroke with the Minnesota Vikings, he had heat exhaustion the day prior to, and he never recovered. So he went back to play in a really uncommonly hot day for that practice after just having suffered some heat exhaustion and some hydration issues the day before. So returning to play is a really big reason why athletes die. So we want to focus on that a little bit today. Again, going back to the pathophysiology of exertional heat stroke, what actually happens to the body when somebody experiences that very high temperature that then remains elevated for a long period of time? It basically affects all your organs. Your entire body starts to shut down. If you could see here, the liver is affected. There's CNS dysfunction, mostly due to that, the hypothalamus controls your body temperature in the brain, and that's affecting the ability to, that causes that neurological dysfunction. The heart is affected, kidneys are affected. A person could become heat intolerant as a result, so their thermal physiology system is damaged, sometimes temporarily and sometimes permanently. And you also have coagulation, so you have basically clogging throughout your whole body, so your circulatory system is not able to function properly. So we'll talk a little bit about that. So when somebody has exertional heat stroke, the severity of the symptoms and the sequelae and the complications that happen from it have everything to do with how high their temperature was and how long that temperature remained elevated. So what happens is you could be exercising in a hot environment, which happens in Texas. I'm from Florida. It's hot every day. It's not as humid here, so you guys are a little bit lucky on that regard. But usually what we have is a compensable heat, meaning you're exercising, your body adapts. That peripheral vasodilation happens. You start sweating. The evaporation of the sweat cools your body, and that becomes compensable, meaning you are able to handle it. Sometimes that becomes uncompensable when your body is not able to handle it, and when that happens, you have that damage to your cell membranes, you have that leaking of endotoxins and cytokines into your circulatory system. Your liver becomes unable to detoxify those chemicals and those toxins, and that's what results in multi-organ system dysfunction. Some people call it systemic inflammatory response syndrome. So when somebody dies from heat stroke, it wasn't just high temperature, it was all the things, a cascade of events that happens as a result. If you could see this figure here, on the top is a compensable heat situation. So at the top you could see you have some kind of exercise heat stress. You have extrinsic factors, the environment, the coach is pushing them, maybe not having access to fluids during practice. On the right, you could see intrinsic factors. Some of the factors that cause heat stroke are if somebody was sick, if they're dehydrated, if they're not heat acclimatized, they're taking certain medications, high body fat content, lack of physical fitness, things like that. So you combine that increases your metabolic rate, increases your temperature, increases cardiac output, skin blood flow, sweat. This is normal response when you're exercising in the heat. Okay, when it becomes uncompensable, you have a decrease in central venous pressure, your temperature goes up, and then all these things that I talked about to your organs start to happen. Energy depletion, cell anoxia, endotoxins, continued increase in body temperature, liver dysfunction, renal failure. All these is a cascade of these terrible things that your body basically is shutting down. Why is this important for heat stroke? Depending on the athlete coming back from heat stroke, you have to make sure that they have recovered from all these things if all these things did in fact occur to them. Some of the clinical signs and symptoms that would be present for heat stroke: elevated core body temperature greater than 105, CNS dysfunction, very similar to concussion situation. I don't know if anybody has dealt with a heat stroke victim that is actually acting exactly like a concussion victim. They're throwing things, they're irate, they're very aggressive, or they're unconscious, not responsive. Okay, so depending, it could be the whole spectrum of CNS dysfunction, difficulty breathing, hyperventilation. These are just some of them. The other ones are something that you would see more in the hospital setting. So hepatic failure, elevated liver enzymes, things that when they come back to you with their blood results, you might see elevated liver enzymes, elevated CK levels, things like that. And just to clarify, somebody that has exertional heat stroke, they're exercising in the heat and collapses from heat stroke, could still be sweating. So I know a lot of people think they stop sweating. That's not necessarily true. Somebody that is exercising in the heat and collapses from heat stroke may still be sweating. So you can't just rely on if they're still sweating, it's not heat stroke. So rely on the elevated temperature and the CNS for diagnosis purposes. All right, so let's talk about return to play considerations following heat stroke. These are the questions that every clinician should be asking themselves. Very similar to anything else that you've seen in athletic training, right? Has the athlete recovered? Somebody comes back from any kind of orthopedic injury. Are they healed? Right? What caused the injury? And then what do we need to do to get them back? So depending on their sport, these are the three things that you should be asking yourself, and it's very relevant, just like it is to orthopedic injury, to heat stroke. So have they recovered? Are they heat tolerant? Are their liver enzymes back to normal? Is their CK level back to normal? And then something that I would recommend that you probably all do anyways on any kind of emergency situation is that you lay in your bed and you just think about all the things that you did. Were you supposed to do something differently? Did you do it right? What could you do better next time, right? So any kind of heat stroke situation that you come across, you want to examine how did you do as a clinician? Could it have been prevented? Did the coaches do something that I need to change? Are we supposed to change practice times, modify equipment intensity? Do we need to do a better job of recognition? Were they treated appropriately? And then EAP, right? Any emergency situation, you should go back to your EAP, and did you follow, what does your EAP say, and did you follow what your EAP did you actually do what your EAP says you were going to do? All right, so some considerations. Has the athlete recovered from heat stroke? Now, this is going back to all those organs and things that are not functioning. This is very important. So you want to know if they have a full recovery or if they have any kind of lasting symptoms or issues. Are they heat intolerant? A lot of times with heat stroke, depending on how severe it was, they may have temporary loss of heat tolerance. Other people have permanent heat intolerance, meaning they're no longer able to push that blood to the periphery. Their sweating response might be altered, and they are no longer able to. So here you can see the definition for heat intolerance: lower thermoregulatory efficiency and the inability to properly adapt to exercise in hot environments. So that's one of the main things you should be determining or working with a physician is, are they heat intolerant? Can they exercise in the heat again? And that's really relevant. Yesterday we talked about cycling and going to high altitude for a trip. That Pittsburgh player didn't play in Denver again, but if you live in Texas or Florida, they're going to be in the hot environment every day, right? So you need to really find out, are they heat intolerant or not? The recovery is, like I mentioned before, very much related. They go hand in hand with the recognition and care that was provided. I've worked some medical tents in some races where they have multiple heat strokes every single year. They know they do, they're ready for it. They collapse, they get their temperature, 107, 108. Medical team is cooling them really aggressively. They are kind of in and out of consciousness. All of a sudden they start coming back to life, literally, and they seem fine. And you send them with their family and you say, make sure you follow up with your primary care. And they walk away, they go to lunch with their family. They probably don't feel well, but they're okay. That person's return to play will be a lot easier than somebody that was not recognized or they delayed cooling. Their temperature was very high up. They potentially needed an organ transplant. Their organs were failing, and then they were in the hospital for a month. That's a much different picture, okay? So the recovery with heat stroke is completely relevant to the recognition and care that was provided. So was it prompt recognition, and were they cooled on site? As you all know, the heat stroke heat on his position statement says cool first, transport second. So you want to cool them on site before you transfer them to the hospital, because that would delay the amount of treatment or the amount of cooling that happens with somebody with exertional heat stroke. So the initial treatment must be on site. The goal is to lower their body temperature to less than 102.5. They will continue to cool after that. The goal is to decrease their temperature within 30 minutes of collapse. So it's not like cardiac, where you have to hurry up and get the AED or call 911 and send them to the hospital as soon as possible. If you remember from that slide in the beginning, one of the reasons that athletes die from heat stroke is immediate transport. So you want to make sure that they're cooling within 30 minutes of collapse, and the length of time that the body temperature is above the critical threshold is basically what dictates their recovery and how much organ damage there is or if they're going to die. So whole body immersion in cold water is the way to go, and monitoring the rectal temperature and their other vital signs throughout there before you transport them. So once they get to 102.5, they could come out of the tub and be transported to the emergency department. And this is basically showing you the key to survival and the key to a faster recovery from exertional heat stroke. So it is important how high their temperature is, but what's more important is how long that temperature stays elevated. This is a very tricky situation here. I'm in good company if I fall, right? A room full of athletic trainers, where else would you want to fall off a stage? All right, so here you go. This is the key to survival. Prognosis is bad. The longer somebody's temperature stays elevated, the worse the recovery for them. Okay, so here you have an imaginary hypothetical person that's at 109. Somebody could get that high with exertional heat stroke. Here you have that critical threshold of 105 or 40.5. The key is to decrease their temperature and not have their temperature stay elevated for a long time. So if you picture an inadequate cooling, like ice packs over peripheral arteries, or somebody that gets sent immediately to the hospital, they're sitting in the ambulance, maybe they have a little imaginary crushed ice pack that doesn't really feel cold at all, and somebody's temperature is at 109, that's not going to cut it. So the longer the time that they're above this critical threshold, the more likely they have that organ damage and potentially could die from it, okay? All right, so recovery. These are the things that as a clinician you should be looking at. Somebody comes back to you following exertional heat stroke. You want to make sure they have normal organ function. You want to make sure they have normal blood values, those liver enzymes, the CK levels, etc. You need to make sure that they're heat tolerant. And as with most things, we want to make sure that a physician has cleared them to participate and begin some kind of graduated return to play process. Okay, so somebody comes back from heat stroke and all their labs are normal does not mean go out there for, do you guys have 2-a-days? Okay, so you come back from heat stroke, cool, doctor says you're good to go, put on your gear and go out there. That does not mean that. That means beginning the return to play process, much like everything else. You know, if somebody gets clear from ACL, you're not just going to put them in full contact with gear, right? You're going to do a progressive return to play. This is just showing you about the recovery. That gray box is basically the 30 minutes of when you want their temperature to decrease, and basically this is when you start the treatment. These are all just different cooling modalities. These that are faster are cold water immersion, different temperatures of water, dousing them with cold ice and water. And all those, if you start about 5 minutes after they collapse, you figure out it's heat stroke, you start cooling them, they're going to be okay. If you delay treatment and their cooling starts much later, then you could see that by the time their temperature gets down under that critical level is probably too late for them to help those organs that are struggling and basically cooking. All right, some of the labs you should be looking at. This chart is just an example of some of the laboratory measures that you'd want to see. Somebody comes back to you from heat stroke, you want to look at their liver enzymes. The AST and ALT, I'm not sure if you guys could see that. It's aspartate aminotransferase and alanine transaminase. Those are liver enzymes. Because of the coagulation and the cell membrane issues during that uncompensable heat, those enzymes start leaking out into the bloodstream, so you get a blood test, and basically you see those liver enzymes that are really elevated. As well as CK levels. It's very common to see exertional rhabdomyolysis with exertional heat stroke, much like you see it together with exertional sickling. So that just complicates things when they have also heat stroke and rhabdo at the same time. I was fortunate enough to work with a high school athlete that had exertional heat stroke and survived very luckily, and then began the return to play process. These were his numbers. So you can see the creatinine is supposed to be for males between 0.6 and 1.2. He was at 2.7. You can see the liver enzymes are pretty low numbers, less than 100, and he was almost at 7,000. CK levels. The analyzer only went up to 48,000. So we don't even know how high it was, but it was definitely more than 45 to 260. So this athlete had heat stroke with explosive rhabdomyolysis, and he almost died. The second question, like I mentioned, is what caused a heat stroke? This is very important. Before any kind of return to play discussion, you need to figure out why did that athlete have exertional heat stroke, what caused it. It's multifactorial, as I mentioned. There's intrinsic and extrinsic factors. And you're basically, for the return to play process, once the athlete is recovered and coming back to you, you have to kind of go back in time and say what happened, what caused it, and then make modifications accordingly and use that basically as a guideline for return to play. These are just a list. There's a list of some intrinsic and extrinsic factors. Again, the intrinsic factors: poor physical fitness, sleep deprivation, lack of heat acclimatization. These are all things that could cause it. So if any of those factors are involved, you want to address that. To give you an example, the case that I just mentioned, I'll talk a little bit about it later, but he moved from a non-hot environment to Florida about 3 or 4 days before that. And then a strength coach says, hey, we need to do some strength testing, conditioning test before you begin football so we know where you're at. Well, he wasn't heat acclimatized. He was probably in a cool environment all summer. So you can see how this is a pretty realistic picture. You know, there's no guidelines, at least not that I know of, for conditioning sessions, right? Everybody knows football is, you know, no equipment. You gradually increase to shoulder pads to full gear. Every state has different guidelines, but as far as conditioning, like preseason or off-season conditioning, there are no guidelines. So it's very easy for all of these factors or a combination of these factors to be present. If that's what causes a heat stroke for your athlete when they're coming back to you, then those things have to be addressed. This is an example of 6 fatal heat stroke cases. This is the Israeli military. We get a lot of the research and a lot of the information and really good cases about heat stroke from the military because they've been dealing with this for a long time, especially in hot environments. So here you can see on the left are the underlying conditions. Some of them are physiological factors up top. Then you have environmental factors, organizational factors. So physical effort unmatched to physical fitness. Has anybody had any of your coaches had an athlete do something they're not ready for? Everybody, right? Physical effort unmatched to physical fitness. They find that big kid in the hallway that's never played football before in his life, but he's huge, and they're like, hey, you should try for football. And they're not ready for that, right? You guys know what I'm talking about. Improper work-to-rest ratio, and then here you have treatment factors, improper diagnosis, improper treatment. So I'm not sure if you could see this, but the top, these are the 6 fatal cases. Again, this is Israeli military, not athletes, but they're marching in a hot environment, exercising for a long time. On the right, you can see how many of these 6 had these factors. This is what's really important to realize when it comes to the return to play process. The number one thing that I often get, what causes heat stroke? Hydration. No. Hydration is one of the things that causes heat stroke. If you look at this bottom number, 6 cases of fatal heat stroke, all the different things that could lead to heat stroke. Each of these cases had between 9 and 14 factors. So when you're thinking about return to play from heat stroke, you shouldn't think of they should have hydrated better. Okay, and I'll refer to that with the athlete that I worked with, where he thought it was hydration, and then he was over consuming water because he thought it was hydration. I'm like, no, kid, it's not your fault. If you moved here from a cold environment and their conditioning coach made you run sprints in the heat when you're not even ready. Okay, there's a lot of factors. So these people had between 9 and 14 risk factors. Return to play from heat stroke, you have to fix these factors before they even go back out. All right, so what caused it? Which ones could be addressed? Organizational factors. Okay, which ones? Heat acclimatization. I don't know, Texas is pretty good, I believe, with heat acclimatization and kind of building up gradually, right? Some states are not so good, some state organizations are not good. So making sure they're heat acclimatized. Now, this is important. A lot of the exertional-related deaths that we're seeing in sport are not happening in the first few days of football practice per se. They're happening the first days of conditioning when they haven't been doing anything for a while. So the first day that they're coming out for workouts. First time they're coming back from like a holiday break. So it doesn't have to be the beginning of the season per se, just any time they haven't been exercising. Sometimes in Florida in March, it'll be 40 degrees, and then the next day it's like 80, and those athletes are not heat acclimatized. So it doesn't have to be in August. Modifying work-to-rest ratios, modifying based on the environmental conditions. There was a really good paper that came out recently by Grunstein that looked at the map of the United States and how the weather is different, right? So Texas guidelines for environment should not be the same as Indiana guidelines for the heat. Okay, so looking at things in your area. making sure that there's rehydration and making sure coaches aren't limiting access to fluids. And then recognition and treatment. Was the heat stroke properly recognized, and was it properly treated on site before they were transported to the hospital? Physiological factors, poor physical fitness. Was the athlete out of shape when it happened? Is there something that should be done as far as from a fitness, building up an aerobic base before they start doing football that should be addressed before they go back to football? And this is definitely something that we saw with our case, where he was out for quite a few days, over a month. So when he came back, he wasn't football ready. He wasn't even like regular conditioning ready. So we had to get him back to that before he even thought about going back to football. Illness or fever, this is a really big one. Was he sick before he participated? I'm aware of a case in a college setting where they were doing conditioning, like weights, and then going outside. And the athlete said to the athletic trainer, "Hey, I don't feel so well. Are you okay? Can you work out?" "Yeah, I can work out. I was just letting you know I don't feel so well." Well, he ended up getting a heat stroke from that conditioning session, and now there's like a big issue about it. If somebody has a fever, or they have vomiting, diarrhea, stomach virus, something they ate for the couple days before they're exercising, that predisposes them. So anytime an athlete comes up to you and says, "Hey, I've been throwing up, can you practice?" "Yeah, I'm good," you probably want to keep them out. Or if they've had any kind of fever, because their temperature that normally is here is now starting here. It's still going to go up with exercise. So kind of changing the policy might be needed if an athlete comes back to you after heat stroke and they were sick at the time. Maybe it just takes a little bit more education on the athletes and coaches, letting them know, if you're sick, you need to let me know, and keeping them out until they're better. Body composition and sleep deprivation are a couple things to education, making sure the athletes know that sleep deprivation could actually make you more susceptible to heat stroke. So education and awareness of these risk factors for coaches, for the athletes, anybody involved in the sports medicine team. So now I want to kind of shift gears a little bit. So I mentioned we don't really have that much information. Any kind of guidelines that we have about return to play from heat stroke are pretty general. There's a lot in the military, and there's a little bit from ACSM and from NATA. So military setting often uses heat tolerance testing, not so much in the United States. They do use it, but they don't rely on it. Other countries rely solely on heat tolerance testing to see if a soldier is ready to go back to combat in a hot environment. As far as the athletic setting, there's ACSM guidelines. The NATA position statement from 2015 did give good general suggestions. The Corey Stringer Institute, hopefully you guys are all aware of that. If you're not, it's out of the University of Connecticut. It's basically a center that started off as prevention of heat stroke and has shifted to preventing sudden death in sport. The website is ksi.uconn.edu. I'm on the Medical and Science Advisory Board for that. There's no money related, so it's not a conflict of interest. It's just education. Just you go on there, and there's a ton of information, handouts you could give to your coaches, things that you could use for yourself. And they have a whole center for testing. So when these really elite, like triathletes and other big name athletes, the case in Towson, Gavin, I want to say, heat stroke athlete, he went there and got tested, and they basically put him through all these kind of tolerance testing to make sure that he was able to safely return to sport following heat stroke. And then in the literature, there's been some more recent case reports. So important things. You must have physician clearance, and you want to have those normal labs before you begin any kind of return to play or return to exercise following heat stroke. In the ACSM, kind of go through this a little bit, but these are some of their guidelines as well, very similar. Return to asymptomatic state, normal labs, cautious introduction of physical activity. And you want to do just physical activity first, kind of a thermoneutral, not so hot environment, and then gradually increase. Same way you would do heat acclimatization in the beginning of the season, short duration, low intensity, gradually increasing the duration and gradually increasing the intensity, and gradually implementing or introducing equipment if it's an equipment sport. These are some of the recommendations from the ACSM from 2010. Their suggestion is to refrain from exercise for 7 days, follow up 1 week post-incident for exam and lab testing, and again, once you're cleared, begin exercise in a cool environment and then gradually progress. Cleared for full participation if they're heat tolerant for 2 to 4 weeks of full training. And this is ACSM and Department of Defense, so it's kind of return to play / return to duty for military setting. So what does the NATA say? In the NATA position statement from 2015, if treated on site, you could go home the same day. And this is something that I've seen in medical tents in different places. They recognize a heat stroke. You cool them aggressively with cold water immersion, cold water dousing, whatever you have available to you, and they're usually okay. If you're on your own at a high school and there's no other medical professionals, I would definitely refer and send them to the emergency department. Even if you cool them and they seem okay, still follow up and send them, okay? And you're talking about a medical tent. Has anybody ever worked a medical tent in an event, races and stuff like that? It's like a little mini ER, right? You have physicians, you have athletic trainers, nurses, PT, everything. So it's kind of like a little mini ER. It's a little bit different. But if you're working out on your own, just you or another athletic trainer, you definitely want to refer them to a physician. Make sure that everything is checking out, all those organs are working properly. If treatment is delayed or not provided within 30 minutes, they are going to have some kind of complication for a while. So that's going to dictate the return to play. So NATA suggests 7 to 21 day rest period, normal blood work, physician clearance, and progression of physical activity. But it's pretty general recommendations, right? It's up to the athletic trainer to figure it out. So the patient needs to be asymptomatic. Normal blood work, you're looking at, again, the liver and kidney enzymes and panels and making sure that their electrolytes and other muscle enzymes like their CK are normal. Gradual return to play, and then using the signs and symptoms of heat tolerance. Are they dizzy? Are they having problems? Are they nauseous? Are they exhibiting signs of heat exhaustion, for example, when you're just having them do some light activity? And then having some kind of graded heat acclimatization progression. All right, so what does that progression look like? What should we be doing as athletic trainers when we're trying to get an athlete from heat stroke back to exercise? Obviously, the athletic trainer should be supervising all the workouts, go from low to high intensity, gradually increase the duration in a temperate environment, and then progress to longer, and then progress to a little bit warmer environment. Monitoring of some sort should be, whether it's rectal temp or you have the ingestible thermistors or something like that, should be monitored throughout. And definitely looking for any kind of signs and symptoms of heat stress during activity. So what's heat tolerance testing? I want to talk a little bit about that because this is something that, unless you've read some of this military literature, most athletic trainers would not be aware of. Heat tolerance testing is used by the Israeli Defense Force since 1979. It's taken different forms. Some of it was like a step test. It's pretty much graduated to a treadmill test in an environmental chamber, so a room where they're able to control the environment and walk on a treadmill for 2 hours. And they basically monitor their temperature, their heart rate, and they're looking for them to plateau. So they monitor their different things, and they have cutoffs. So if their temperature gets to 101 and they're just walking on a treadmill, or if their heart rate gets above 150, then they need to cut them off. Okay, so you're looking for some kind of plateau. This is information that you could use in your setting to monitor their temperature and monitor their heart rate. You know, if they're doing light activity and their heart rate is through the roof, then you know that they're probably not ready yet, and they need to kind of bring it down a little bit. All right, I'm going to skip through some of this stuff, but I want to show you what it looks like in a graph. So here you have somebody that did a heat tolerance test at 2 months post and 5 months post their heat stroke. Okay, so you can see on the left is their core body temperature, and on the right is their heart rate. Not surprisingly, you guys see the lack of plateau there, right? They started walking on a inclined treadmill in a hot environment, and their temperature just shot right up. It's not supposed to do that. That's a number one sign of heat intolerance. Similarly, you can look at their heart rate on the graph on the right, and they started walking, and their heart rate, there's no plateau there. It just kept climbing till reach the cutoff, and they stopped them from that activity. 5 months later, though, this same person was able to maintain their body temperature doing the exact same thing. So sometimes with return to play and heat intolerance, it just takes time. It's a temporary lack of heat tolerance that they just need time to recover from. This is another example of somebody on the left that's temporary heat intolerant versus somebody on the right that was just heat intolerant permanently. Okay, and we've seen this in a couple of cases in marathon runners, but it was a Marine Corps marathon. So the couple Marines where one athlete was cooled at the medical tent. The other athlete, there's an actual paper called The Tale of Two Heat Strokes, if you've seen it. The second athlete they found him on the course EMS, and they couldn't get to the medical tent, so they just sent him to the hospital. Well, the person that was treated on site and cooled in the medical tent was able to return back to duty in about a month. The person that was literally EMS got them on the race course and took them directly to the emergency room, and that person, because of the delay in cooling, became heat intolerant and was discharged from the military. He's no longer able to participate in the military. And it all had to do with somebody, the EMS, picking him up immediately after collapse and sending him directly to the emergency room. Okay, so that really affects the heat intolerance part. So here you can see somebody was temporary, I don't know if you can see that, but temporary intolerant, and then by the third test became heat tolerant. This is core body temperature, this is heart rate, whereas this person on the right, by the third test, they still were heat intolerant. So basically, they recommend testing, and then if they're not tolerant, just wait a few weeks or wait a few months and then test them again, depending on the situation. And this is a pretty good algorithm. I did send Natalie the handout today, so I apologize that you don't have it with you just yet, but it's a pretty good algorithm. I can't read it from here, so I'll read it from over here. So basically, it says warrior athlete heat stroke event after 1 or 2 weeks of rest. Clinical assessment. If it's a normal exam, begin light exercise, gradually increase the workload, increase the exposure over 2 weeks. If it's not a normal exam, so the labs are still elevated, wait 2 weeks, do the labs again. Okay, if somebody begins to exercise and they're fine and they've basically done a 2-week type of progression of exercise and they seem heat tolerant, then you just monitor them closely and let them go back. If somebody is not, they don't do well with the exercise, you might consider a heat tolerance test. So that's how they use it in the military. They try other things first, and if they're heat intolerant with regular exercise progression, then they look at the heat tolerance test. Now I want to go to some individualized return to play, because this is all great, but if you don't have a heat chamber, then you really can't do anything with it. So there have been some recent cases looking at specific athletes. The other issue, too, that I have with the general recommendations that we have so far from NATA and ACSM is that they're very generalized. So you can't, somebody comes back from heat stroke in cross country and somebody comes back from heat stroke with football, those are very, very different return to play progressions, right? So you need to be able to fit it to your sport. So in this example, they had an elite triathlete that had 2 cases of heat strokes 2 months apart. Talk about not going back and realizing what caused the heat stroke in the first place. You have a heat stroke and then you have another one 2 months later. They're not doing what they need to be doing to prevent the reoccurrence of it. But basically, the return to activity in this case, the point I want to make is that it was a cycling return to play. They used cycling and they used different intensities. They tested him before and after. They make sure that he was heat acclimatized, and they monitored all these measures throughout the testing. Day 6 to 14, they moved him to an environmental chamber and monitored him a little bit more closely. And then by day 15, second exercise heat stress, he was able to perform 70 minutes before cycling. But this is great, but if he's doing a really long triathlon or Ironman, 70 minutes is probably not going to cut it. So again, the return to play needs to be reflective of the actual activity that they're going to be performing. And this is just an example of the temperature and the heart rate. So these are the main benefits from the heat acclimatization process, okay? It's not just to delay when they start hitting and you start getting orthopedic injuries, but from the heat standpoint, their heart rate will decrease as a result of heat acclimatization, and their temperature will decrease as a result of heat acclimatization. So here you can see on the top is a gastrointestinal temperature. So they take a little gastrointestinal temperature pill that sits in your gut, and you get a little remote control to monitor that. And here is your temperature, and here is your heart rate, just a regular chest strap heart rate monitor. And you can see before heat acclimatization, this triathlete's temperature is way up, and his heart rate was way up. And then after heat acclimatization process, they were able to bring those measures down. Those are the things that you would be looking for when you're observing a return to play progression from one of your athletes that has heat stroke. These are just also symptoms. So also monitoring symptoms and how the athlete feels. Are you dizzy? Are you weak? Are you nauseous? Do you feel like you have a fever? Do you have any pain? And again, using the symptoms and the physiological measures during the return to play progression to see how they're doing. So in this case, he was not able to, for the cyclist, he was not able to do the 90-minute cycling test at his racing pace. It is unknown if they ever reach a plateau. So that's another thing. Do these people ever reach their plateau if they're doing an all-out sprint for a race? So that's something that is a little bit difficult to mimic in the return to play progression aspect. This is another case of a 53-year-old recreational runner. And basically what it came down to in this paper is that they were looking for what caused a heat stroke in order to help the return to play progression for a runner. Okay, so again, looking at the sport and the needs of the athlete, what caused it, have they recovered? Those are the 3 questions. Have they recovered from their heat stroke? And what caused it in the beginning, and then looking at their sport. In this case, it's a recreational runner, and he wanted to be able to safely compete in the race a year after he got his heat stroke, okay? And there you could see it, that he was able to successfully complete the Falmouth Road Race from one year to the next, and the numbers are not as important right now, other than the most important number is the finishing body temperature. When he had his heat stroke was 42, and then the next year was 39.67. So it was elevated, but that's pretty normal for somebody exercising in the heat. And here you can see the comparison of one race, year 1, 2013, his temperature versus year 2. In both cases, he was cooled with cold water immersion and didn't have too many lasting effects from the heat stroke. Now I want to go to a more athletic type of situation. A really interesting thing happened. I was putting together this book. It's called Quick Questions on Heat and Hydration. So I was putting together this book and had all these colleagues of mine helping with different sections. And I asked a colleague of mine to create a return to play functional progression for a sport setting for athletic trainers to be able to use. Before the book was even published, I was contacted by a physician in the local area that said, I have this high school football player. He's in the hospital right now. I'm going to release him from the hospital, but I have no idea how to get him back to football. Like, I don't know what the latest information says. Everything I see is pretty general. And I was like, well, it so happens that I have this protocol. So this is one of my friends and colleagues, Brendan McDermott. I told him I named it the McDermott protocol, so now he's going to be famous. But I was able to actually use this protocol that he created on an actual high school football player that had suffered a heat stroke. So it's a progression of exercise duration and intensity, progression of equipment and environment, and it includes stopping criteria. You want to be able to monitor them to see if something is not right, you need to stop them. Do you guys have a return to play, like a state concussion protocol? And I apologize, I don't know that. I know Florida's. Okay, so it's probably like a graded test where they get to something. If they do well, they go back to the next step. If they don't do well, they go back. Is that kind of how it works? So very similar concept here, where you're monitoring their heart rate, you're monitoring their body temperature. If their heart rate goes over 90% of the heart rate, you have to think it's very easy exercise. It should not even be getting close to that. Then something is wrong and you need to stop their that testing for that day and kind of take it back a little bit. Same for the temperature. The temperature should be plateauing. It should increase with high intensity exercise, but if it's not really that intense and their temperature is shooting through the roof, then you know that they're probably not quite heat tolerant yet. And then also monitoring for any kind of signs and symptoms of heat stress. So here's an example of that protocol. Day 1, light activity, stationary bike, jogging, no more than 30 minutes, no protective equipment. Days 2 to 4 should be assessed based on the responses from day 1, just to see how they're doing. Did they feel okay with 30 minutes on the bike? Then maybe progress to a little bit more difficult, increase the percentage of their heart rate, put a heart rate monitor on them, figure out what their resting heart rate is, figure out what that range is, and then monitor that accordingly, right? If they're doing basic exercises that are really easy, their heart rate should not be shooting up too much. If that goes well, days 5 to 7 include moderate activity, 50 to 75% of activity, up to 1.5 hours. So now we're getting a little bit closer to actual practice type duration, right? You can't just do 30 minutes every time and then put them out on football practice. So you have to do a gradual increase. Sports drills are acceptable. So you could start implementing their sport-specific activity. Day 8 to 10, start introducing protective equipment. So if they don't require protective equipment, you could just skip 8 to 10 and just go from day 7 to 11. So we've had athletes with football that have heat stroke. There could be basketball athletes that get heat stroke during conditioning. So obviously the equipment is not going to be as relevant for the return to play protocol. And as you can see, it just progresses from day 11, day 12, all the way to 13. Day 14 is the final progression. And keep in mind, it doesn't have to be 14 successive days. In the case that we used, we had some setbacks with our athlete. So he basically went across 3 weeks by the time he finished the 14 days. Okay, this is just kind of, if you think you should do 3 days at step, of day 7, that protocol, then just do that until the athlete is able to sustain that type of activity. All right, so now I'm going to show you an example of a real-life clinical application. This is the high school football player I was talking to you about. Collapsed during a conditioning test. He was diagnosed with heat stroke and exertional rhabdo, admitted to the ER for 11 days. He had renal failure, abnormal labs. He was sent directly from the hospital during the conditioning. There was not an athletic trainer on the field at the time. and he almost died. Very lucky kid. He should not have, he got lucky, basically, that he's alive. Most of the data that we see of somebody that collapses like that during conditioning, goes to the hospital, usually dies after a few days or is in coma for a while and then dies. So very lucky kid. So this physician contacted me and was like, what do I do? And I was like, well, I have a protocol. It was one of those things. Talk about evidence-based medicine. You have your clinical experience, right? You have the research, and you have the patient values. Okay, it's not all about, I hear a lot of people say, I have 20-some years of experience. That's good, but let's bring some of the research. There's some there are researchers that don't even take into consideration the clinical experience, right? You can't take one of them out. You got to use both of them. So we had the research. We had all the information to create this protocol. We had the physician and the athletic trainer with their clinical experience, and we kind of merged them together and said, well, let's try it with this athlete, see what happens. His labs were monitored weekly upon discharge. He began the progressive return to football. Once those labs were normal and the physician was like, okay, I feel good, his labs are normal, let's start the exercise protocol. And basically we got that McDermott protocol and we modified it to this athlete. He was a high school defensive end. He was in the hospital for 11 days and then not cleared for quite some time. I believe it was about 38 days before he got that clearance from the physician, so he was out quite a bit of a time. We addressed predisposing factors, and we worked with the strength coach and with the sports coach. If I'm going to start incorporating sport-specific activities, I might want to ask the DN coach, what should this guy be doing? If he's supposed to be at this intensity, not game speed, this intensity, we're just starting out. Can you run him through some drills? So the athletic trainer and his coach having him run some drills. The athletic trainer's monitoring all his physiological and perceptual symptoms, and the coach is running the exercise program, working together on this. It was pretty cool. So he completed this functional progression protocol across 3 weeks. There you can see the monitoring device. This is the ingestible thermistor. Okay, so you take this little pill. It is expensive, and the monitor is even more expensive, but they do loan it out. And if you're anywhere near somebody that does research with heat stroke or heat illness, they might lend it to you. Don't tell them I said that. I lent it to them, so I'm assuming that they would do the same thing. So we monitor his temperature, heart rate, his RP, ratings of perceived exertion. If you're having him on the bike and you're like, how hard are you working? And they're like, extremely hard, then you know something is, maybe he's not ready to start exercising yet, right? The athletic trainer also monitored his urine color. Okay, so make sure he's hydrated and had him pee in a cup right before practice. Take a look at his urine color. Okay, see how hydrated he was? We measured his body mass before and after and calculated his sweat rate as a result of that. And we also monitored how much he was drinking. Okay, so we basically took the protocol that already existed and included basically things that were relevant to this athlete. Okay, so these are the types of exercises. Basic sit-ups, push-ups, 10-minute drills, football-related, very light, and gradually increased. This is his maximum heart rate and temperature. Okay, so his heart rate is, hold on, I can't see from there either. I should probably walk around. His maximum heart rate is a solid line, his maximum temperature is a dotted line. Okay, he lost the pill on day 4, that's why there's a blank spot there. But he was still able to be monitored without the temperature. So you can see across the 14 days, and it got progressively harder, the exercise, across that. And you can see on day 12 was an easier workout, day 14 was full football practice. And then so that was his maximum, this is his mean. So you can see the average throughout the 14 days pretty much balanced out. And then this is what's really interesting. We also measured his body weight before and after. His fluid consumed. Anybody notice something unusual about day 1? Okay, I'll help you out. 30 minutes on a bike, indoors. He consumed 2.8 liters of water in that time. The Gatorade bottles are a liter. He had 2.5 bottles, 30 minutes of exercise indoors. A lot of patient education had to go into this because he thought he got heat stroke because he was dehydrated, and he drank 2.5, almost 3 liters of water in a 30-minute indoor cycling exercise at light intensity. Okay, so he did get better throughout the week. You could see, if you look at the pre-post body weight right in the middle, So anything positive means he gained weight. He should never gain weight during exercise. When you're exercising and you're sweating, you should always lose a little bit, not more than 2%, but some body weight. You should never be gaining weight because that's over hydration. So you could see by the end he was pretty much evening his intake, his sweating to his intake. But that was definitely some patient education that we had to do there. So what we learned, this patient was not heat acclimatized when he did the conditioning test. Remember, you have to find out, is he cleared, is he recovered, and what caused it? He was not ready for that conditioning test. He was not heat acclimatized. The protocol that we used had to be individualized. So even though we did have some set recommendations, his heart rate, just the first few days of sit-ups, push-ups, was way over like the 50 to 60% of heart rate, which means he was not physically fit either. He was not quite ready for that exercise. The protocol didn't include resistance training. I had the strength coach saying, he might be in good shape cardiovascularly, but I'm scared for his strength. Like, he is not ready to be a D end and get hit and have a guy, try to plow through guys. So we had to incorporate the strength and conditioning aspect too, because remember, the last step is, what is a sport? What is the sport requirements? What are the metabolic demands of his sport? So we had to increase the resistance training, and that was added week 2, because he was definitely not football ready. He had continuous follow-ups with the physician, which slowed the process, but we were okay. The physician sent him to a cardiologist and had him do stress tests and make sure that his heart was ready for the type of activity required for football. As I mentioned, he was overhydrating quite a bit. Really good communication was necessary. I was kind of like a accessory athletic trainer. I would go out there on some of the days, but I was not his athletic trainer. He had an athletic trainer. So the physician, the athlete, his athletic trainer, and myself worked really well together with the strength coach and the football coach to get this kid back. He did return to full participation without incident, even though he did end up missing, I think, the first 5 games of the season, which is quite a bit. And he's currently playing at the collegiate level. So it was a successful process. Again, to reiterate, returning to play following heat stroke in the high school football, has the athlete recovered? Normal labs, any kind of complications, heat intolerance, physician clearance. What caused it? Was the athlete heat acclimatized? What's their physical fitness status? Are they ready for that kind of activity? Determine their fluid needs and address any kind of organizational or other predisposing factors. So are the work-to-rest ratios fair? Does he have any kind of predisposing factors, medications he's taking, or illnesses that would predispose him again for a heat stroke? And then what are the needs? Looking at the metabolic system demands and applying this information to some kind of gradual return to play for the individualized for that particular athlete. So what do you need to implement this? You need a heart rate monitor. You need some kind of accurate body temperature monitoring, whether it's a rectal temp or a gastrointestinal thermistor. Monitoring the signs and symptoms of heat stress, very simple. There are some symptom checklists out there, or you could just ask them, how do you feel? Are you dizzy, nauseous, anything like that? Monitor their hydration status, also very simple. You can make sure that they arrive hydrated before practice, have them pee in a cup and look at their urine color, 1 to 8, closer to water would be hydrated, darker apple juice, not so hydrated. You don't want them to begin practice in a dehydrated state. You could do the most effective way to measure hydration during practice is to get immediate pre and post practice weights, body weights, which I know a lot of athletic trainers do. You could also look at their urine-specific gravity and calculate their sweat rate if you have the calculations. In order to do sweat rate, you have to measure how much they drink during a given practice and figure out what those needs are for those athletes. Because you could have 2 football players very similar size. One of them should be drinking 3 liters of water at practice, and one of them should be drinking 1.5 liters of water at practice. So you want to make sure that the recommendations are individualized for hydration. And then you need an exercise protocol working with whatever coach is necessary to do something that will really work for that particular athlete, their sport, and their position. So I have a few conclusion slides. It's important to note that exertional heat stroke is multifactorial. And knowing the causes, not the causes, there's always going to be more than one cause. Knowing the causes of the heat stroke is what should guide your return to play process. Figuring out what happened, why did it happen, and then addressing those factors before they go back. Children can be at greater risk for heat gains. It's interesting when you look at the data, those 58 heat stroke deaths from 1980 to 2009, about 40 of them were high school athletes. So there's a huge, the athletes that are dying from heat stroke in football are mostly the younger athletes. I don't know if it's lack of medical care. I don't know if it's due to thermoregulatory insufficiency. If they're not mature, I'm not sure what the cause is, but that's definitely the focus area. Where should we be focusing our educational focus for preventing death and preventing heat stroke in that population? Education is key for prevention, recognition, treatment, making return to play decisions on that. The recognition and the treatment of heat stroke has a huge impact on the return to play process. So just remember, if you're able to recognize heat stroke accurately on the field and cool them on site before you transport, cool first, transport second, that is going to make, it's literally a lifesaver. Like, it's going to make a huge difference whether they survive, and then if they do survive, how many residual complications they're going to have as a result of the heat stroke. Evidence-based guidelines should be used for all athletes of all ages, and it's important to remember that heat stroke could lead to some kind of heat intolerance in this athlete. So somebody that has heat stroke isn't necessarily more likely to have heat stroke again. It just depends on what caused it and if they have recovered from it, if they're heat intolerant. There's people that have heat stroke and are completely fine and never have a heat stroke again because those issues were addressed. Okay, so determining the initial causes is the key. Last one, I promise. We definitely need more research and more guidelines for return to play following heat stroke. There's really not that much out there other than general recommendations. But what we found based on this case especially is that it's very feasible for athletic trainers to implement an individualized graded functional return following an exertional heat stroke patient and get him back to sport safely. So that's what I got. I'm open to questions. Hopefully we have some time. Do we have time? Yes. Thank you for the golf.
Let me ask this one first. Is there a specific test that is performed to determine whether an athlete is no longer heat tolerable?
I would say the best way to do that is to, there is the heat tolerance testing, which is basically walking on a treadmill for 2 hours and monitoring their temperature and their heart rate. That is a heat tolerance test as defined by the military and is often used. But as an athletic trainer, you could do some kind of cardiovascular test. It could be walking in the treadmill in the heat. It could be walking around the track in the heat, if that's what you have. I mean, you guys have an environmental chamber outside. So do I. You just go outside and it's hot. But the important thing is monitoring their temperature and their heart rate and looking for, when it's moderate to light activity, looking for that plateau in those physiological variables. If you're not getting that plateau and their temperature and their heart rate are shooting up, then you know that they're heat intolerant.
John, thank you.
Good morning.
Hi.
I had a question as far as this sounds like a big patient care plan for post-heat illness. My concern would be probably insurance coverage for all the labs you're requesting, and also what kind of physician, I mean, other than the orthopedic surgeons we work with, would you have involved in this type of patient care plan for this heat illness type of situation?
That's a great question. From my understanding, if you send an athlete to a hospital, they're going to get those labs done. So the question is, if you get those labs and they're abnormal and the athlete is released from the hospital, they're probably going to follow up with their primary care physician.
Their primary care, okay. So,
Yeah.
for example, now, as far as, since we only have accidental insurance, would this be considered a heat-related accident or illness?
Oof, that's a good question for the insurance company. I'm not sure, to be honest. I'm not sure how that would work. If it's definitely like part of the school function, I would think that it would fall under that, but I'm not sure how that insurance works.
And as far as your liberal profiles, that would probably take a prescription from a physician for a follow-up, which means you're going to have time to take this young athlete to his primary care if he has one. And if he doesn't, what do you do?
Well, I mean, I think it's similar to any other condition where you need a physician clearance. I mean, it's not up to the athletic trainer to figure that out. I think it's more they have a heat stroke, they get sent to the hospital. If they're not ready to participate and you need a physician's clearance and approval, they're going to have to go to a physician to get that approval. I guess
what I'm saying is that all of us as athletic trainers down here in this part of the neck of the woods, we'll always have that argument with our coach. Well, get the kid cleared. They say, yeah, but he doesn't have a primary care. What do I do? Because, the reason why I'm saying this is because not everyone is really insured outside of the health care plan the school provides.
So if you have a concussed athlete that needs to be cleared by a physician and they don't have insurance, what do you do?
I don't know.
You let them play, or they're just not cleared?
No, that's not the point. The point is the concussion is a different. It's not different. It follows the same protocols. But the thing is, as athletic trainers, we're going to be left with a dilemma on who do we send this child to if this child doesn't have a primary care. I mean, where does the responsibility begin, and where does the responsibility end to bring this child back?
I think the responsibility of the athletic trainer is to make sure that they're cleared by a physician before you let them back on the field. I think it's the responsibility of the parent to determine if they get the proper health care. I mean, I can't.
And also, okay, so then you would have to, the reason why I'm saying this is because this is something that, I think all of us in here would be contemplating, upon our return to our different types of, jobs. But I guess what I'm asking too is how much administrative support would you need to have this completed at your schools?
I don't think any. I mean, any administrative support you would need for the administration to say you're the athletic trainer and you decide when somebody returns to play. I don't think it's any different than any other condition that you're dealing with.
Okay, thank you very much. Appreciate it.
You're welcome. Other questions?
Another question is, what type of ingestible pill do you recommend? Can these be kept in hand in the athletic training room? Are they prescribed only those going through the return to play?
Great question. Unfortunately, there's only one, maybe one company in the United States that sells them. They're out of Florida, actually. It's called HQ Inc. I do not work for them. I just use their products. It's not prescription. It's FDA-approved device. It basically has a radio transmitter that they ingest. You have to ingest it 4 to 6 hours prior to. So if you've ever worked with, there's some big-time collegiate football programs that use them in the preseason. They get all their guys to take the pills for the couple weeks before football officially starts, and they monitor them. So you don't need a prescription. It's not a medication. However, you need money. So it's not as easy to do. So you have to. That's why I said in this case, the school, it was a private school. The school paid for the pills, and I loaned the device that actually takes the temperature. So it's not, hey, everybody could do it. I totally get that. So if you could do this with any other kind of monitoring, I know this is a hot topic, but rectal temperature is kind of the way to go. Other than any other temperature device, but if you're not going to measure temperature, then you go with heart rate and the other physiological measures and your clinical expertise. Ideally, you want the temperature, though, because that's the whole point. You want to make sure their temperature is not spiking.
And of course, people were asking, besides rectal temperature, you just mentioned the other options.
Yes, I absolutely would. In any case of heat stroke, I would not use any other temperature location. So if you use tympanic, temporal, those are all going to be inaccurate. So you don't want to use that because it's going to change your course of action. So if you're not going to get a rectal temperature, go with other clinical findings, other vital signs. But you don't want to use an inaccurate device that's going to change the course of your treatment.
Okay, thank you.
Any other questions? Okay, thanks again. I appreciate the invitation to be here.